Hi, good evening all. We are here for the basic module in infectious diseases, cycle 2. I welcome you all for this presentation today evening. The topic is on antimicrobial dosing in obesity, which will be presented by Dr. S. Swati Samban. So let me just introduce the speaker for today evening. Dr. Swati Samban, graduated from Amrita School of Pharmacy, Amrita Vishwa Vidyapeetham. She's currently working as a clinical pharmacist in Infectious Diseases Department, Amrita Institute of Medical Sciences, Kochi. She's a project coordinator into many projects like Community COVID Resilience Resource Center and Amrita TB Free Village program. She's a project coordinator for Integrated AMSP AI project, AIMS Kochi as well. She has done various research and publications on topics like prospective observational study to assess the efficacy and outcome of octreotide and midodrine in the treatment of cirrhosis-associated hyponatremia. And next article is on insight into the role of alpha-fetoprotein in the development and progression of hepatocellular carcinoma. Next is on COVID-19 associated pulmonary aspergillosis risk in low and middle income countries, a matched case control study under review in open forum infectious diseases. Let me give guidelines for the participants today. Slide change. Can you just change the slide? Yeah, the participant guidelines are, you can post your questions, type your questions or responses in the comment box and click the submit button. Your questions will be answered at the end of the session. You can submit your feedback by pressing the feedback button that is available below the comment box, and the feedback becomes disabled after the live session. You can claim your certificates. The certificates will be issued after the attendance. That will be issued within 14 days after the attending the event. If you're watching the event on YouTube, you will have to log into our website and register for the event to claim your certificate. You can download the slides in PDF format from the website. Login is mandatory to download the file. Now let's begin with today's topic, antimicrobial dosing in obesity. Yeah, the stage is yours.
Okay, thank you, Dr. Nistila Reddy, for the kind introduction. So let's move on with the topic. So the topic for the day is antimicrobial dosing in obesity. So disclosure information, I do not have any relevant financial relationships with any commercial interest. Now the learning objectives for today is we'll be going through introduction to obesity, underlying challenges in pharmacokinetic features of dosing in obesity, dose optimization in obesity, and what are the current recommendations and what are the clinical implications. So we can say antimicrobial dosing in obesity is more like the battle against infections in the era of obesity, which is a multifaceted challenge. So why do we say it's an era of obesity? So actually the prevalence of obesity has increased considerably over the past few decades. So what the WHO says is like in 2016, if it was approximately 2 billion adults who were overweight and out of which 650 million were affected by obesity, by 2025, it is estimated like 2.7 billion adults will be overweight, and out of which 177 million will be affected by severe obesity, will be severely affected by obesity. So now what is the challenge in here? You have an obese patient who is given a standard dose of a drug, then there is the chance of underdosing. And what comes with underdosing? When there is underdosing, there can be increased hospital stay, increased incidence of antimicrobial resistance, there can be increased morbidity, mortality, etc. Moving on, obesity. So let's define it. So obesity is a pathological condition that is defined by an abnormal or excessive accumulation of fat tissue. And this excessive accumulation of fat tissue has a possible impact on the health through comorbidities. So we can say that the total body weight. So this is very important. So we'll say total body. We have certain terms here in defining obesity and learning about obesity. So the first one we can say it is the total body weight. So the total body weight or the actual body weight in a normal weight person, the lean to adipose weight ratio will be 4:1 ratio. That is, a lean will be 4 and the adipose weight will be 1. So when it comes to obesity, in obese individuals, the excess adipose weight is accompanied by 20 to 40%. There will be increase in the lean body weight. So this increase will further result in lean to adipose ratio changes. So if the initial ratio was 4:1 ratio, now the lean to adipose weight ratio will be approximately 3:2. So there is a change that has happened. So one of the most commonly used classification for obesity is the BMI. So BMI is the body mass index, is a statistical index using a person's weight to provide an estimate of body fat in males and females of any age. Yeah. Also, we have the equation for calculating the BMI. So the BMI is equal to weight in kilogram divided by the height in meter square. And once we have done this for a patient, now we can look into the BMI classification. So according to the BMI classification, after getting the result, applying the equation, the patient can be categorized into severely underweight, underweight category, normal weight category, overweight category, and the obese category according to the values that you get. Now, if the patient is above 30, that is BMI greater than or equal to 30, we'll say the patient is obese or is in obesity. And if it is greater than 30 kg per meter square, that is BMI greater than 30 to 34.9 kg per meter square, we'll say the patient is in obesity class 1. If it is between 35 to 39.9 kg per meter square, we'll say it is obesity class 2. And BMI greater than or equal to 40 kg per meter square, we'll say the patient is obesity class 3, or we'll say the patient is morbidly obese. So now we have some equations for calculation of body weights. So the first one is the body mass index, as said before, that is the total body weight in kilogram divided by height in meter square. Now we have the body surface area. So body surface area, as we know, we use it for our chemotherapeutic drug calculation in pediatric dosing. We use the body surface area. So we have different equations. We have the Du Bois equation. We have the Mosellas equation. So in Mosellas, what we do is we'll take the square root of height in meters into total body weight, and that will be divided by 3,600. Moving on, we'll be having the ideal body weight calculation. In ideal body weight calculation for males and females, we have different equations. For males, it is 49.9 plus 0.89 into height in centimeter minus 152.4. And in females, it is 45.4. So that is a difference there in males and females. In females, it's slightly lesser. In males, it is 49.9, and females, it is 45.4 plus 0.89 into height in centimeter minus 152.4. Next, we have the lean body weight calculation. That is also different in males and females. In males, it is 9,270 into total body weight divided by 6,680 plus 216 into the BMI. And we have a slightly different different numbers in the females. Next, we have the adjusted body weight. That is very important. So adjusted body weight, to calculate adjusted body weight, you need to initially calculate the ideal body weight. So once you have the value for ideal body weight, only then you can calculate the adjusted body weight for the patient. So adjusted body weight, the equation is ideal body weight plus a correction factor into total body weight minus ideal body weight. So usually the correction factor will be between 0.3 to 0.6. We usually take it around 0.4. Now let's move on with some calculations. It's a very simple calculations. To have a clearer picture on how to dose for obese patients, we need to have a basic understanding on how to apply these equations and do the calculations. So the first question is, what is the BMI of Mr. A? So the weight of the patient is 95.45 kg and the height is 6 feet 3 inches. So as we know, we want it in kg and meters for the calculation of BMI. This is our equation. BMI is equal to weight in kg divided by height square of the height in meter square. So I have provided two clues. So one of them is 1 feet is equal to 12 inch, and next is 1 inch is equal to 2.54 centimeter. So these are the options. A is normal weight, overweight, obese, and morbidly obese. So Dr. Nistela Reddy, I think you can check on the comment box if we are getting any answers for this. Ma'am, am I audible?
Yes.
Yes. We'll just take a minute to see if I get some answers in the comment session.
Yeah.
So this is more like of a simple calculation where we can directly apply the equation. Apart from the thing that we need to make some conversions to convert the 6 feet 3 inches. Okay, we'll look into that. So this is our question. To calculate height in meters, we initially need to convert the 6 feet 3 inches. So as I said before, 1 feet is 12 inch. So 12 into 6 plus the extra 3 inches will give us 75 inches. So next we need to convert the 75 inches into centimeters. So 1 inch is equal to 2.54 centimeters. So calculating it, we get 190.5 centimeters. Now the centimeters needs to be converted to meters. So that is 1.905 meters. Now we can take the square of the height, that is 3.62 meters square. And when we apply the equation of BMI, we'll get an answer of 26.3 kg per meter square. So it's option B, that the patient is overweight. Okay. So the next question. Next question, it's similar to the first question. Like we need to calculate the BMI. But here the only change is that the weight is in pounds. So it's 210 pounds and you need to calculate for this. So let's see. So this is a clue, that is 1 kg is equal to 2.20 pounds. Okay, I'll move on with the answer. I hope that there is no any answers in the comment section. Okay. Moving on with the answers. So see here, it is 1 kg is equal to 2.20 pounds. So 210 pounds, when we do the conversion, we'll get 95.23 kg. And now we can change the 5 feet 4 inch. So that will add up to 64 inches. And when we take the square of the height, it is 2.64 meters square. And when we apply the BMI equation, we'll get it as 36.07 kg per meter square. The patient is in the obese category. Moving on. So I would like to go through a question, an example of body surface area calculation. So what is the body surface area for a patient weighing 60 kg, height of 168 centimeter, we need to calculate the dose of the drug X with a concentration equals to 135 mg per meter square. So how can we do this? We know the equation. It is square root of height in meters into total body weight divided by 3,600. So when we take the square root, we'll be giving in all the values that is known. We'll give the numerics and we'll get the answer as 1.673 meters square. So once we get the answer, dose of the drug can be calculated directly. We'll substitute, that is 135 into what we have got as a body surface area, that is 1.673. We'll get 225.8 mg. So that's answer. We have some more calculations. So these calculations are given to have a good understanding about these variables, whether it is adjusted body weight, ideal body weight, or absolute, the adjusted body weight. So once we have a good clarity regarding all these terms, only then we can move to the dosing in obesity. So what is the ideal body weight for Mr. Z weighing 60 kg and 5 feet and 5 feet 7 inches tall? So this is the equation for calculating ideal body weight. In males, we have the equation of 49.9 plus 0.89 into height in centimeter minus 152.4. Nishla madam, should we wait since it's some max calculations? Should we give time or shall we move on?
I don't see any responses. Maybe they're still calculating or they're not posting on YouTube.
Yeah. Okay. So let's move on. So when we substitute the equation and when we calculate the height in centimeters, so here we want the height in centimeters. So once we do the calculations, we do the conversions, and when we substitute, we'll get the answer as 66 kg. So that is how we calculate the ideal body. So as we know, the ideal body weight calculations are important because to do the adjusted body weight calculations, we need the ideal body weight calculations. So knowing the ideal body weight is important to dose in obese patients. So this is one equation for ideal body weight calculation, and always keep in mind it is different equation for males and different equations for females. So this is similar question where we want to calculate the ideal body weight, but here I am using a different equation. For the last question, I used a different equation. Here, the equation that I am using is for males, the ideal body weight is equal to 50 kg plus 2.3 kg for each inch over 5 feet. So what we are doing in this equation, when we are substituting this equation, what we need to keep in mind is that whenever the patient is over 5 feet, that is 5 feet, and if you are given like 5 feet 7 inches, we need not consider the 5 feet. We only consider the 7 inches. Anything above the 5 feet. So the equation is like ideal body weight is equal to 50 kg plus 2.3 kg for each inch over the 5 feet. So this is the equation. For females, you have a different equation. Ideal body weight, it's not 50. We'll take a lesser value, that is 45.5 kg. So these are all fixed equations. You can directly substitute your values to these equations. So that means that you can either use this equation or the previous equation for ideal body weight calculations. So I'm just showing you two different equations. It's up to your convenience. You can substitute your values in any of these equations. So for females, ideal body weight is 45.5 kg plus 2.3 kg for each inch over 5 feet. So the ideal body weight here is 50 plus 2.3 into, we ignore the 5 feet because we only consider anything above 5 feet. So we'll take the 7 inch. So that means it's 66 kg. So next we can look into a question where it's slightly different. So we have 6 feet and 7 inch. So what is the ideal body weight for Mr. Y, who's 60 kg and the height is 6 feet and 7 inch. So as we said before, still 5 feet, it's fine. anything above 5 feet. So we have options A, B, C, D. So I think we'll give them a minute for this calculation. You can use any of the equations for calculating the ideal body weight. Any of the equations can be used. Just make sure the conversions are right. Okay, ma'am, Nishla ma'am, do we have anything in the comment section?
No.
Okay, let's move on here. So here, if we are taking the ideal body weight equation for males, 50 kg plus 2.3 kg for each inch over 5 feet. Uh, the only tricky part here is that anything above 5 feet. That means we have an extra 1 feet there. So 1 feet is equal to 12 inches. So then 12 plus the extra 7 inches that we have, that will add up to 19 inches. So then you can directly substitute 50 plus 2.3 into 19, that is 93.7 kg. So it's option B. Yeah, so which way to be used in obese? So now you have a question. Okay. If obese, the total body weight, if it is greater than 30% over the ideal body weight of the patient, then we can use the adjusted body weight for the calculation. So this is the general information. If the patient is obese and the total body weight is greater than 30% over the ideal body weight, you can use the adjusted body weight. So let's take an example. Calculate the creatinine clearance for a 62-year-old female patient who is 5 feet 6 inches tall, weighing 90.9 kg with the serum creatinine of 1.8 mg per dl. So this is the question. So here the tricky part is one thing, we shouldn't be using the equations and formulas for males. It's specific here, it's a female patient. So we need to have in mind, we need to use the equations where it's different for males and females. So those substitutions should be clear. And the 5 feet 6 inch conversion should be right. Okay, we'll move on with that. So here the total body weight of the patient, it's already mentioned in the questions, it's 90.9 kg. And the ideal body weight can be calculated. It's 45.5 plus 2.3 into 6 because it's 5 feet 6 inches. So we have ignored the 5 feet and we have only taken the 6 inches. So we'll get the ideal body weight, which is 59.3 kg. So now we look whether the total body weight divided by the ideal body weight into 100, we'll get 153%. So that is over 30%. So when it is over 30% for creatinine clearance calculations, we can use the adjusted body weight. So that's it. You need to use the adjusted body weight for the calculation. So this is the equation for adjusted body weight. So once you have your ideal body weight there and you made sure that the ideal body weight and the total body weight, the total body weight is 30% over the ideal body weight, then you can use the adjusted body weight. So then comes the adjusted body weight equation, and you will use your ideal body weight values substituted into the equation, and you will find it out. And this adjusted body weight, which you have found, that is 71.94 kg, that will be used for your creatinine clearance calculations. So I hope it's clear. Okay, so moving on. So as we were discussing, there are different measurements, but with all these measurements, there are certain issues. So if we are taking the body mass index, there are some limitations to the body mass index, because if there are two people weighing, I mean having the same height and having the same weight, and we calculated that BMI, but for one person it can be the fat, the weight of fat, but for the other person it can be the muscle weight. So actually body mass index doesn't differentiate between the muscle and the fat mass. So we cannot say, we cannot just look into the body mass index and say that the patient is, or the person is healthy, or the person is unhealthy, or the person is obese to that extent. So it corresponds to different degree of adipose tissue in different individuals. Next, we have the body surface area. So this also has the same issue, same similar issue. It's just taking the surface area of the body. So this does not account for the composition of body weight, adipose versus lean tissue. They are not looking into it. And in its application in some extreme weights is controversial. We have the ideal body weight, and the problem with ideal body weight is it was initially not even designed for the drug dosing. So it was one of the LIC companies that came up with the ideal body weight calculations. So it's not for the medical calculation of the drugs. It cannot be much used for the medical calculation of the drugs, and it does not consider the lean body mass. So next we have the lean body weight. So lean body weight, then we can know what is the lean body weight, but it is a bit difficult to calculate it. It is bioelectric impedance analysis and specific equations are there. So it is not, may not be readily available for the practical setting or in the clinical setting. It may not be readily available to do calculations using lean body weight. So now what are the challenges in obesity? So obesity, definitely we have increased risk of infections. There is an impaired immune function. There is altered immune system dynamics. There is compromised respiratory function. There is increased risk of surgical infections. Pharmacokinetic and pharmacodynamic alterations are there. There can be risk of overdosing, underdosing, and when there are fixed dose combinations, it can be challenging to dose in obese patients. And we have lack of data. That is, there is no inclusion of obese patients in the FDA drug development process. So when it is not there in the FDA drug development process, we have very limited data. We have a trouble, like in newer drugs, there are some clinical trials in which they tried with obese patients, but for majority of the drugs, there are no much data in which they have studied it in obese patients. So for this, we need to understand the ADME, the drug absorption, distribution, metabolism, and excretion. So understanding the ADME in obesity. So in an obese patient, if we take absorption, there will be delay in the gastric emptying. There will be alterations in the gastrointestinal pH according to the food consumptions. There will be increased adipose tissue will be there. In obese patients, the distribution will be affected. There will be an increased volume of distribution. There will be alterations in the plasma protein bind. It will affect the metabolism, the hepatic metabolism, and the enzyme activity of different enzymes. And we know all of these enzymes are required in metabolism of different drugs. In elimination, it will affect your renal function, the glomerular filtration rate, and all of these are dependent for all the calculations. See, if there is a difference in volume of distribution, then definitely there will be a difference in elimination. So since all of these are connected, there will be alterations in obesity in all of these factors. So moving specific with volume of distribution. Initially, we need to know whether the drug is hydrophilic or lipophilic. Hydrophilic means the water-loving ones, and lipophilic means the fat-loving ones. So we should have an understanding about what are the hydrophilic drugs and what are the lipophilic drugs. So in hydrophilic drugs, we have the beta-lactams, the glycopeptides, the aminoglycosides, the daptomycin, polymyxin, fosmycin, etc. And in the lipophilic category, we have the fluoroquinolones, the macrolides, the tetracyclines, the tigecyclines, sulfamethoxazole, clindamycin, rifampicin, etc. So let's see what happens in volume of distribution in an obese patient. That is, first we look into hydrophilic drugs. Hydrophilic drugs are the water-loving drugs. So for hydrophilic drugs, they do not readily enter into the adipose tissue. So the patient is an obese patient, and we are administering the patient and hydrophilic drug. So hydrophilic drug is a water-loving drug. So this water-loving drug does not readily enter into the adipose tissues. So for that patient, if we use the total body weight of the patient to calculate dosing, it may overestimate their volume of distribution. So in such cases, it is better to take the adjusted body weight. So adjusted body weight might be more accurate in measuring for determining doses in these cases, because otherwise it can be an overestimation. Next, when it comes to lipophilic drugs, total body weight suitability, when we look into the lipophilic drugs, if the absolute volume of distribution increases in obese patients and the volume of distribution divided by the total body weight ratio remains similar between the obese and the non-obese, it suggests significant drug distribution into the adipose tissue. So if the volume of distribution divided by the total body weight ratio remains similar between the obese category and the non-obese category, that means the drug has been distributed to the adipose tissue. So in such cases, in an obese patient, if the drug has been distributed into the adipose tissue very well, then in such scenarios, total body weight becomes more suitable to measure and to calculate doses, particularly in lipophilic drugs. So this is the basic understanding. So there is also a role for lean body mass and the blood volume. The increased volume of distribution of hydrophilic drugs in obese patients can also attribute to augmented lean body mass will be there. The blood volume will be altered, which may account to 20 to 40% of overweight individuals can have increased lean body mass and blood volume. So now, if we take some special scenarios like surgical prophylaxis considerations. So volume of distribution is crucial in the context of surgical prophylaxis, where it is necessary for us to achieve a higher drug concentration in the skin and the adipose tissues. We need a higher concentrations because it is surgical prophylaxis. So it is essential that in surgical prophylaxis, we have adequate drug concentration in the skin and the adipose tissue. So in obese patients, the low perfusion in these tissues in obese patients underscores the need of careful dosing to ensure that the patient is receiving adequate prophylaxis, or else it can be underdosed. So there are differences in perfusion. So the local blood flow to the adipose tissue is relatively low. So estimated to account for only 5% of the cardiac output will only be reaching the adipose tissue, compared to 73% received by the lean tissue will be receiving the 73%. Only a less amount will be reaching the adipose tissue. So this disparity actually leads to poor peripheral perfusion in obese patients. Yes. Next one is lower antimicrobial drug concentrations. So the combination of increased volume of distribution and poor perfusion, peripheral perfusion, together may result in low concentrations of antimicrobial drugs in subcutaneous adipose tissue. So this can potentially impact the effect of surgical prophylaxis and treatment of infections in obese patients. So now we have this figure. So when we look into this figure, when we consider the first image, so this is for a normal patient. So in the normal patient, the volume of distribution will be proper. The volume of distribution divided by the ideal body weight will be proper. Volume of distribution divided by the total body weight will be proper. And the Cmax, the T half will be fine. But next image, you have an obese patient administered with an hydrophilic drug. So what happens is when there is obesity, the volume of distribution increases. But the volume of distribution divided by the ideal body weight increases. But the volume of distribution divided by the total body weight decreases. The Cmax reduces. The T half is also altered. And when we come to the final image of the highly lipophilic category, we have a threefold increase in the volume of distribution because it is lipophilic, highly lipophilic, and the drug will be distributed. The volume of distribution divided by the ideal body weight will be increasing. The volume of distribution divided by the total weight will total body weight will also be increasing. The Cmax will be reducing. So that's very important that the Cmax gets reduced. And we know when the drug is not above the Cmax, or when the drug is not achieving the Cmax, what happens? Will not be getting the effect that we are foreseeing. So the T half will also be extended in such cases. So this diagram shows the physiological changes in obesity and what are the parameters that influences. So we can see that there will be increased cardiac output will be there. Oral bioavailability will be affected. As said before, the gastric emptying time will be increased. The gut permeability will be increased. There will be increased adipose tissue will be there. Tissue penetration will be reduced. There will be poor peripheral perfusions will be reduced. As said before, there can be alterations in the liver enzyme, the CYP3A4 activity, etc. So there will be alterations to them. In the kidneys, the GFRs can initially increase and later on decrease. So there will be increased tubular secretions in obese patients. So there are certain pharmacokinetic properties that are happening in or changes that are happening in obese patients. So now we need specific recommendations. So we need specific recommendations saying that reflects the need for tailored therapeutic approach based on drugs, pharmacokinetic and pharmacodynamic profile, and the patient's body composition. So it's not like if there is an obese patient, you can increase the dose, or if it is a lean patient, you can reduce the dose. It's more of a tailored therapeutic approach where we look into the pharmacokinetics and pharmacodynamics of the drugs, and then we dose it. So according to the relationships between the drug exposure, pathogen susceptibility, and clinical response to antimicrobial treatment. So we have to keep this in mind. So we do the adjustments keeping in mind about the drug exposure, which was the pathogen isolated, and what is the susceptibility of pathogen, what is the MIC of the pathogen, that is a mean inhibitory concentration of the pathogen, how the patient is responding, what is the clinical response that patient is giving to the antimicrobial therapy. Suppose you have an obese patient and you initially dose the obese patient with a normal range, the patient is not responding, then you need to look into the pharmacokinetic pharmacodynamics of the drug. We need to know what whether it's lipophilic, hydrophilic. We need to look into the clearance of the patient. Then only you can dose it. It's tailored up. The antimicrobial drugs can be divided into three categories, as we know that. We can say the Cmax by MIC dependent drugs. We have the AUC by MIC dependent drugs. We have the time dependent drugs. So we have the concentration dependent, AUC dependent, and the time dependent ones are there. And see, in this will give a more clearer picture. So you have a normal host and you are giving a drug to the normal host with normal weight, normal clearance, normal patient. So then the peaks are achieved. Adequate time, it's the drug is above the MIC levels, and we get good clinical outcomes. Whereas in an obese patients, the time the drug exposure time gets reduced because there is increased clearance is there. So the drug is not above the MIC for a longer duration or as expected in a normal host. So it gets excreted. So we have a lower peak and we have early clearances there. Now this is with the killing of organisms. So in normal host, when an effective killing of all susceptible organisms take place, when it comes to an obese host, what happens is killing of organisms only with lower MIC values is only possible because the drug is being cleared earlier so that it doesn't get enough time to be above the MIC. So killing of organisms only with lower MIC values. Now we'll go into specifically into different drugs. So first we have the aminoglycosides. So the gentamicin, the tobramycin, the amic acid. So when we look into the drug characteristics, the aminoglycosides are hydrophilic drugs. They have low volume of distribution. and renal elimination. And when we look into the PKBD, it is concentration dependent. So there can be changes in obesity. So there can be increased volume of distribution, increased renal clearance, and we have already have studies supporting that recommended setting for dosing in obese is we take an adjusted body weight. And so this is pretty clear. Like you have an hydrophilic drug, that is a water-loving drug, and the patient is obese. So if we are trying to give according to the total body weight of the patient, it can be an overestimation. So it is recommended that we give an adjusted body weight. With in adjusted body weight, we have the factor C. So for C, we can give the value. Before I have said it is between 0.3 to 0.605. So we'll take the correction factor as 0.4 for the initial dose, and you can use whenever it is possible, you can use tedium to guide your dosings. Okay. So now we'll take an example. You have a 75-year-old male patient. Height of the patient is 72 inch and the weight is 140 kg. So amikazin, it's 5 mg per kg. So if we are ignoring the fact that the patient is obese, we are just substituting, then we'll get it as 5 into 140, we'll get 700 mg, and we'll write the 700 mg. So what if we consider the patient is obese? You'll get a different answer. Let's see. We'll calculate the ideal body weight. You have the total body weight or the actual body weight of the patient, which is 140 kg. Now we will try to calculate the ideal body weight. Ideally, what should be the body weight of the patient? So this is a male patient. So the ideal body weight is 49.9 plus 0.89 into height in centimeter minus 152.4. We'll get the answer as 77.02 kg. Now, using this ideal body weight to calculate the adjusted body weight. So now we have the adjusted body weight. So adjusted body weight equal to ideal body weight plus the correction factor into total body weight minus ideal body weight. So if we are substituting this here, we'll get 77.02 plus 0.4, that is a correction factor, into 140 minus 77, you will get 102 kg. So you can see the difference here. It's 102 kg here and this is 140 kg. So if we are substituting that in our amicus in mg per kg, you will get 5 into 102, that is 510 mg only. So can you see the difference here? That is, if you would have taken the normal weight, it would have been 700 mg, which is a scenario where we are overestimating. But we should have used the adjusted body weight and given only 500 mg to the patient. So this is the relevance. So next we have our beta-lactams, which is very commonly used. So when we look into beta-lactams, we know that the beta-lactams are hydrophilic in nature. They are time-dependent antibiotics with the renal clearance. So the target PKPD is 100%, so it should be above the MIC or 4 into MIC in cases of patients who are critically ill. So in obesity, the increase in lean mass, and there is an increase in the lean mass and there is an increase in clearance. So what we generally recommend in beta-lactams is that to start the treatment with beta-lactams at higher doses in obese patients with complicated infections, keeping in mind infections caused by microorganisms with higher MICs, in critically ill patients, or those whose clearance is increased. That is, you have a clearance that is above 100 ml per minute. In these cases, we can go with a difference from your normal dosing. So we need to keep in mind if you are dosing for dosing a beta-lactam for an obese patient, you can look whether it's a complicated infection and whether the organism that you got from the cultures and sensitivity is having a higher MIC, patient is critically ill with high clearance. What can you do? Also, you should take into consideration the source of infection should be considered, especially when it is bone infections being one of the most difficult to treat in obese patients and requiring an increase in the dose. So the recommendation is to reduce the frequency of administration or to use an extended or a continuous infusion. So one thing you can do is to reduce the frequency of the administration or to use it as an extended or continuous infusion so that the drug level stays above the MIC for longer durations and you'll get the expected outcomes. So wherever you can do a TDM for dose adjustments, you can please go with that. So TDM is preferred for the dose adjustments. So this paper was from the OFID, was published in the OFID. So in this paper, they have looked into the effects of obesity in the clinical failure of patients treated with beta lactams. So what they have done in this study is they have taken around 257 obese patients. So they had an obese group and the non-obese group. And the most common infections like urinary tract infection and respiratory infections. So for those infection, I mean, those people who are infected with urinary tract infections and respiratory infections, they have looked into the efficacy of third generation cephalosporin, cefepime. They have looked into its effect, and what they have concluded is that obese patients treated with beta lactams have higher rates of treatment failure is happening and also longer hospitalization periods when compared to non-obese patients. So this was their conclusions. So now we have another paper where surgical site infection rates is higher following hip and knee arthroplasty when cefazolin is underdosed. So here also patient undergoing hip and knee arthroplasty and with the weight above 80 kg or those with weights more than 120 kg, they concluded that they should receive cefazolin doses 2 grams or 3 grams respectively. But they couldn't actually conclude more about if the patient is overweight more than 120 kg, whether to increase the dose in such a way. So we have such studies, and this was the impact of obesity in the efficacy of ceftriaxone. So what they concluded, this study, they conclude that obese patients treated with ceftriaxone were more likely to experience a clinical failure when it's compared with non-obese patients. So we have a couple of studies that say that if we are not ignoring the obesity part or we are not adjusting the doses according to obesity, uh, there can be changes in the clinical outcomes, or there can be there it can affect its efficacy. So moving on with cotrimoxazole, sulfamethoxazole, trimethoprim. So for sulfamethoxazole and trimethoprim, even if you look, this is pretty well known. Even if you look into the up to date, you can see that we use the adjusted body weight for the calculations. The adjusted body weight with the correction factor of 0.4 can be used for the dose calculations. So we have a range of 80 to 20 mg of trimethoprim per kg per day divided, IV divided into several doses. So when we are taking oral route, as when we consider the oral route, 5 mg per kg per day is suboptimal in obese patients. So we need to increase the doses. We need to adjust the doses according to the adjusted body weight in obese patients in sulfamethoxazole trimethoprim. Now we have the glycopeptides. So glycopeptides, they're hydrophilic agents. So they are predominantly cleared by the renal elimination. And PKPD is AUC MIC dependent. And for vancomycin, we usually use the total body weight and the TDM at the trough levels. So when it comes to drugs such as vancomycin, we have very established TDM values and we can know the trough levels. Then it's pretty straightforward to dose in obese patients. I'm not saying very okay, but we have the TDM values to titrate the doses. So we have the loading dose of 20 to 25 mg per kg, maximum to 3 kg IV, and we have the maintenance doses. Same with ticoplanin. The dosage, we use the total body weight in dosing for ticoplanin. And in deep infections, we recommend a slightly higher dose. That is, we can give 15 mg per kg, has been described in studies. So you can keep in mind in ticoplanin, you can have higher doses in deep infections. We have evidences for that. Now, moving on with the lipopeptides, we have the daptomycin, which is a hydrophilic antibiotic. So It's highly protein bound and lower volume of distribution and renal elimination. And PKPD is AUC bar MIC dependent. So in obese patient, when there is increased volume of distribution and decreased clearance is there, adjusted body weight may be used in place of total body weight if there is concerns of toxicity, especially in settings of indications for higher dose daptomycin. So if you are planning to give a higher dose daptomycin in obese patients, as we know in obese patients, there is increased volume of distribution and clearance. We can use the adjusted body weight rather than using the total body weight for dosage calculations. Next, we have the linezolid. So linezolid is a time-dependent antibiotic, and the goal of effectiveness is, it's AUC by MIC, and there is increased volume of distribution and clearance in obese patients, and there is high risk of treatment failure when you are using the usual doses. So the risk is higher with decreasing in age, and EGFR is greater than 60 ml per minute, and the MIC values is greater than 2 mg per liter. So in these cases, higher doses of linezolid can be given in obese patients, that is 600 mg 8 hourly. So if there is a possibility of TDM, then you can do your TDM. So it's 600 mg every 8 hours in obese patients. That's the evidences. So coming towards the end. So this was a paper published in 2024. So this is very good for everyone's references. So this is updated antimicrobial dosing recommendations for obese patients. So they have pretty well listed out all the antibiotics and what are the recommended doses in obese, and when, what kind of what dosing calculation, what parameters you can use, whether it is to use the adjusted body weight or the total body weight. So for example, you can see in Amicus, they have recommended to use adjusted body weight. In trimethoprim sulfamethoxazole, they have recommended the use of adjusted body weight. For each of the drug, they have given the recommendations, so you can go through this paper. In voriconazole, in IV, they have recommended the use of adjusted body weight, and we know that in voriconazole we can do the TDM levels. So whenever it is possible to do the TDM levels, make sure we do a TDM level to make sure that it doesn't reach the toxic levels or it is not being underdosed. We have cidofovir, the acyclovir, for which we have evidences for using the adjusted body weight. So now I would like to give some takeaways. So it's more like we need a tailored therapeutic approach based on the PKPD profile of the patient's body composition. So we need to know what are the comorbidities of the patient and what drug we are planning to administer to the patient. So it is not like, as we always say, it's not like one size fits all theory. So it's more of a balance between the risk and the benefit for underdosing without increasing toxicity or overdosing. So we should take into consideration the relationship between the drug exposure, what is the susceptibility of the pathogen, what is the MIC of the pathogen, the clinical response to antimicrobial treatment. You give the normal dose, is the patient responding to it? What's the clearance of the patient, and the individual patient characteristics, such as if the patient's kidney is impaired, and how should we consider, what are the other drugs the patient is on. So we need to have these ideas when we are dosing for obese patients. So these are some of the references. So we have some upcoming events. So tomorrow, 12th of May, we have antimicrobial dosing in patients on peritoneal dialysis. It will be taken by Mohammed BH. So stay tuned for this. And next we have the obstructive shock that will be taken by Sri Vishwapal. So these are the upcoming events. Now it's time to take any questions. Thank you. Thank you so much.
Thank you. Thank you for discussing in detail about the dosing of antimicrobials in obesity. Today we have learned a lot more about where to consider for what antibiotic, what kind of dosing do we have to consider, and how should we have to go ahead when there are any PKPD dynamics that is involved in dosing of the antimicrobials. So let us take a couple of questions. So the first question is on if there's any loading dose that we have to give, do we have to consider the weight even for the loading doses if there's obese patient?
See, now we initially loading doses. Before we used to adjust the loading doses very aggressively. Even the loading doses we used to adjust. I mean, the initial, if we are taking meropenem, if the patient is having a bad creatinine clearance, we used to adjust it. But now in sepsis condition, if the patient is in sepsis or if the patient is in septic shock conditions, we don't actually adjust the initial loading dose. So according to the drug's pharmacokinetics, if it is lipophilic or hydrophilic, or we already have an established idea whether to use adjusted body weight, then you can adjust. You can take the adjusted body weight into the calculations. But if not, you can directly go with your normal loading doses because it's a loading dose. We want the drug to reach there. So for loading doses, we can it's fine to use if we have evidence, search for the evidence, and if you have evidence with the adjusted body weight calculations, you can use that, or else you can go with your normal loading dose calculations.
Okay. Nice. So coming to the next question that we've got, if there's a patient who is obese and renally impaired, so what do we have to consider? Should we have to go ahead with the obese calculation, or should we have to go ahead with the creatinine clearance calculations?
Same same like the question before. If the major cause of the patient's condition, if if it is induced by the sepsis, or if it is a sepsis induced alteration in the clearance, or if it is a sepsis induced AKI, we need not go much with the adjustments of the drug. So at least for 48 hours, if it is in the critical care units, 48 hours, you need not much get bothered or worried about the creatinine clearance. So once the sepsis gets cleared, then the creatinine clearance is supposed to increase. But if it is already kidney injury patients, then you can adjust the dose and accordingly you can uh, dose your drugs.
Oh, yeah. Thank you so much for giving us the insights about the dosing in antimicrobials in obese patients. Thank you. Thank you all. Good
Okay.
evening.
Yeah, good evening. Thank you. Thank you so much.